Welcome to the Chronic Report. I'm Nicole Stewart-Selleck, and I'm joined here today with my co-host,
Dr. Patrick.
Good morning, Patrick. Today we have a wonderful guest on our show. We have Dr. Richard Horowitz, who is a board-certified internal medicine and medical doctor of the Hudson Valley Healing Arts Center, an integrative medical center specializing in the treatment of Lyme and tick-borne diseases. He has treated over 13,000 Lyme and tick-borne disease patients in the last 30 years. And he is one of the founding members and past president-elect of ILADS, which is the International Lyme and Associated Diseases Society. He's also the author of several books, including Why Can't I Get Better? Solving the Mystery of Lyme and Chronic Diseases, and How Can I Get Better? An action plan for treating resistant Lyme and chronic illnesses. Dr. Horowitz, I can't begin to tell you how honored I am to have you here today. Patrick and I were planning who would be our dream team of the first 2 weeks of our new podcast, The Chronic Report, who would be on that list, and you are at the top of the list. And we are super excited that you agreed to come talk to us today, and thank you so much. Patrick, what do you have to say?
I'm thrilled, Dr. Horowitz. I'm thrilled you're here. You've been a key doctor in person in regards to me learning your work. I've studied your work a lot, and I've studied your work over and over again, and you've been a key component to how I treat people clinically. So thank you for your work. Very grateful.
Yeah, welcome, and let's begin. Well, first of all, Dr. Horowitz, we're very interested in knowing about how you came about becoming the Lyme expert that you are. How did you come into this?
Oh, it was completely by accident. When I finished my internal medicine residency at Mount Sinai in New York City, I had two choices. My mother wanted to open me a medical practice in Bayside, Queens, where I grew up. Mm-hmm. And I had been studying meditation when I was in Belgium with the Tibetan Lamas, and there was a meditation center in upstate New York, which was very close to Vassar Brothers Hospital and St. Francis. And I'd been up to the upper Hudson Valley for, many times actually getting meditation teachings. So I went to my Tibetan Lama at the end of my third year of residency. And I said, Lama, my mother wants to open up a place in Queens, but I really like upstate. And, it's beautiful up here. And he did what's called a mower, a divination. And he said, oh, up here, very good. So it was essentially my spiritual teacher who did a divination and said, oh, going up to the Hudson Valley is very good for you. And it's like, one thing completely changes your life, because obviously if I had opened up a place in Bayside, Queens, I don't think I would have been doing as much Lyme disease. Maybe right now it would be, but certainly not 40 years ago when I moved up here. So I just moved up into the largest Lyme endemic area at that point in the United States, which was Dutchess County, New York. I had no idea the tick-borne epidemic was so bad. I came up here in 1987. And at that point, it was shortly afterwards, I was seeing people with erythema migrans, rashes, and I'll get into it a little bit, but even several years after that, I was the first doctor to diagnose babesiosis, which is a tick-borne malarial parasite. I started picking it up in patients, and at the time, the health departments and insurance companies did not believe my findings. That's a whole nother story. But let's just say that it started early on, basically just trying to, help patients who are ill. And I would say one of the most important teachings I got, which in a sense, it's so funny how you learn certain things and you never expect how they're going to affect you. I went to my spiritual teacher, Lama Gendon Rinpoche. My 7th year medical school, by the way, in Belgium is a 7-year medical program in French. Mm-hmm. So I was finishing my 7th year. And I never thought actually I'd be good in languages. That's a whole nother story.
Are you fluent?
Yes, I'm fluent in French. The whole training program was in French.
Okay, all right.
And so I went to him my last year of medical school, and I said, Rinpoche, what is the advice you'd like to give me as a doctor before I go out into the world? What is the most important thing I should know? And he said, well, Richard, the most important thing is compassion. Put yourself in people's shoes and do for others what you would want done for yourself if you were ill. They call it exchanging oneself with others. It's kind of a classic Buddhist teaching. It's not something I would say was that unusual, but the fact that he told me specifically to do it going out into the world as a doctor, I thought, okay, I'll integrate that. And then I find myself in the middle of a Lyme epidemic in Dutchess County. And although, roughly 75% of the people got better from antibiotics like doxycycline, about 25% weren't. And I would send them to rheumatologists and neurologists and psychiatrists, right? To every subspecialist I could think of, because we didn't really have the answers. We just knew that, we treat it with a short course of antibiotics, and then we didn't know why people stayed ill, and they didn't have answers. So I had to start going to Lyme conferences, reading the medical literature. And that started basically, a 30 plus year journey trying to figure out in these 13,000 plus patients why they were chronically ill.
Wow.
Yes. Okay. Good deal. Dr. Horowitz, you've tested well over 10,000 people, and you've been able to categorize people's symptoms based on their positive laboratory diagnostics. When people come to you with chronic immune reactions, whether they appear to be malarial type of infections, Lyme disease, Borrelia type of infections, or other type of immune reactions, and they test negative for all the above, their CBC panels look good, their CMP panels look good, their anti-nuclear antibodies, their other inflammatory markers are normal, but they have persistent chronic immune reactions. What would be your method of treatment?
So what I was just asking, when you're saying chronic persistent immune reactions, are
Yes.
you referring to like inflammatory reactions like SED rates, CRP, C4A, TGF beta 1? Are you referring to that? Or you're just talking about people with symptoms that sound like and smell like
Yeah.
Lyme disease, but the classic testing is negative?
Correct. That's it. Yes.
So first of all, the most important thing for everyone listening is that Lyme is a clinical diagnosis, and the laboratory testing is essentially used to confirm the clinical diagnosis. So you don't really make the diagnosis based on a lab test. And one of the ways we diagnose it is I validated a symptom questionnaire with State University of New Paltz researchers. This was, I think we published it back in 2017 in the International Journal of General Medicine. And we took 1,600 people in 3 medical practices, and we looked at their symptoms, and we looked at statistical scores to figure out what were the most common symptoms they have. Were there any symptoms that stood out that were, that we see on a regular basis in chronic Lyme? And some of the ones that we found in this questionnaire that was done with my good friend, Dr. Phyllis Freeman and Dr. Mariella Cetera, is that we found that migratory pain was the hallmark of both acute and chronic Lyme disease. So this questionnaire was based on Dr. Boriscano's earlier questionnaire. And what I did with the questionnaire by validating it was to put mild, moderate, severe as far as symptoms or based on frequency. And both types of the questionnaires, by the way, work. It's a 38 item questionnaire. Questions 1 and 22 relate to Babesia, this malarial parasite. Questions 1 are fevers, day sweats, night sweats, chills, flushing. Question 22, air hunger, can't seem to catch my breath with a cough. Those symptoms are very classic with babesiosis, this malaria-like parasite, although of course they can be seen in other diseases. But it turned out that if you had a chronic fatiguing musculoskeletal neuropsychiatric illness, and people said that their joint pain, their muscle pain, and or their nerve pain, the tingling, numbness, burning, stabbing sensations that would migrate around their body, the migratory pain was really the hallmark of chronic Lyme. So it's very easy to fill out the questionnaire. In fact, it's on our website, www.cangetbetter.com. If you search under the tab, you'll find the questionnaire. You can download it and fill it out. And a score more than 63 is 2 standard deviations above the mean, meaning you have a very high probability of having chronic Lyme. If it's in the 40, 50, lower 60 range, it's a moderate probability. It's kind of in the high 20s, 30s, lower 40s. It's a mild probability. If it's below 23, it's not likely you're going to have chronic Lyme disease. But this questionnaire, the beauty about it is that, we ask people in the second part of the questionnaire, have they had tick bites? Have they seen an EM rash? Do they have migratory pain of these different types? How many days in a month are they ill physically, mentally, emotionally? And we also have a Lyme symptom score if they score positive on fatigue, joint pain, muscle pain, headaches, neurocognitive symptoms. So we validated the questionnaire We find it to be very, very useful. And we use that as a screening tool, as a pre-test probability. Now, if a test, we don't use CDC positive two-tier testing. That's used for health departments to diagnose Lyme from an epidemiological standpoint, but not for an individual practitioner.
Okay.
But there is a way to use the bands on the Western blot, or primarily immunoblot. I prefer the immunoblot from IGeneX because it checks for 8 strains of Borrelia. So the problem with using a standard lab like Quest or LabCorp or BioReference, they only use 1 strain of Borrelia burgdorferi, but there's over 10 strains at this point in the US that are actually pathogenic that can make people sick. So the IGeneX immunoblot checks for the 8 major strains, and I play a game with patients called Lyme Bingo. So if you have any one of the following numbers, kind of playing bingo on your Western blot or preferably immunoblot, the 23, the outer surface protein C, the 31, the outer surface protein A, the 34, the outer surface protein B, the 39, very specific, or the 83/93 bands on an immunoblot, any one of those bands in the right clinical setting, such as migratory joint pain, symptoms are coming and going. I have fatigue, I have pain, I have memory concentration problems, and you've ruled out things like B12 deficiency, folic acid deficiency, hypothyroidism, sleep disorders, things that would cause cognitive issues. Even one of those bands in the setting of migratory pain is significant for exposure to Lyme. The problem with the Western blot is that the 31 band, the OSPE, can be seen in things like Epstein-Barr reactivation or autoimmune disease. So it's still probably going to be Lyme, but there are overlapping factors. But that's kind of essentially, how we do it is we look at the clinical picture, but you always have to do a differential diagnosis. So for example, if they fill out questions 1 and 22 with day sweats, night sweats, chills, flushing, air hunger, cough, I have to make sure they don't have malaria. They haven't been to India, although Texas and Florida now at this point, actually, they're finding some malaria,
Right.
but that they don't have hyperthyroidism. They're not in menopause. They don't have brucella, Q fever. If they have a cough, sometimes with blood, hemoptysis at night, that they don't have tuberculosis causing drenching night sweats or non-Hodgkin's lymphoma. So the key is always differential diagnosis. And in both in my first book, my New York Times bestseller, Why Can't I Get Better? And my second book, my national bestseller, How Can I Get Better? If you are not someone who memorized every differential diagnosis under the sun, pages, I think it's like 50 to 66, lays out for each symptom the differential diagnosis. So if you say, I have neuropathy, I have tingling, numbness, stabbing sensations, burning sensations, numbness in parts of my body, you might remember that, diabetes will do it with neuropathy, pregnancy, hypothyroidism, B12 deficiency, folic acid, but also heavy metals, mercury, lead, arsenic, autoimmune diseases can cause it. So you want to have a differential diagnosis because if someone has migratory neuropathy, which by the way, Lyme is the only disease known at this point that we know of that causes migratory neuropathy. The only asterisk to that I would put is we don't know with Bartonella because when we did the study years ago, we don't really know how many people had BART because the testing at that point could not test for all the species of Bartonella that were out there. But essentially, if you've ruled out these other causes of neuropathy
Right.
and it's migrating,
Yes.
again, with good and bad days, symptoms coming and going, you take antibiotics, you feel better. You take antibiotics, you feel worse, which is a Herxheimer reaction. You're killing off the bacteria.
There you go.
And women will usually say around their menstrual cycle that they get worse because when the estrogen goes down, the bugs tend to come out. In that particular setting, you can clinically suspect you have Lyme, and that's where you want to look at those bands on an immunoblot to confirm exposure.
Right on. Well
That's
said.
interesting.
Yes.
Yeah.
Yes.
I'm curious. You'd mentioned before we start interviewing that you have recent developments in how you do your protocol, and your current protocol you're using Dapsone, doxycycline, and rifampin for chronic Lyme symptoms. How has this changed treatment for your patients?
Oh, this has been a 100% game changer. So, because I've been doing Lyme for, at this point, I've been in medicine for 40 years, but it's probably 35 at least I've been seeing these Lyme patients. Over the years, we knew that Lyme persisted. Although there has been a political situation with Lyme of 2 separate guidelines, the Infectious Disease Society of America that says Lyme is easy to diagnose and cure. And if you have symptoms more than 30 days, we don't really know why you're sick. It might be an autoimmune reaction. They don't really give you a clear answer. The ILADS guidelines, of which, as you said, I was one of the founding members, and I was just at the ILADS conference in San Antonio. Some of my colleagues like Joe Borascano, who I founded ILADS, was there, including Barbara Buckman, the prior executive director, who we honored on Saturday night. At the time, we thought Lyme persisted because of what we called cystic forms, otherwise called cell wall forms, S forms, L forms, cell wall deficient forms. And I had published an abstract at one of the earlier Lyme conferences where we found that flagyl or tinidazole seemed to hit these cystic forms. And we thought that was the reason people stayed chronically ill, that it was hiding in parts of the body and we needed to hit these cystic forms or cell wall deficient forms. Well, we didn't know until about 10 years ago that Lyme was what is called a biofilm persister bacteria. So what does that mean? So when you go to the dentist and you have to get your teeth cleaned, you have plaque on your teeth, and there's bacteria underneath like Porphyromonas gingivalis that has now been associated with not just gingivitis, but also even Alzheimer's disease, because it's getting up into the brain and it's part of the reasons people are getting sick. And you've got to take off that biofilm. You got to get the dental assistant, to use the ultrasonics and remove the biofilm to be able to get to those bacteria and take the plaque off. Well, it turned out up until 10 years ago, about at the same time, Johns Hopkins researchers, and it also showed up in Stanford University, Kim Lewis's lab, Eva Shoppe's lab at the University of New Haven, they found that these biofilm forms, these persister forms, were actually one of the major forms that were causing Lyme patients to stay sick. Now, what does it mean to be a persister bacteria? Well, we knew it persisted, but a persister bacteria is like tuberculosis or leprosy. And the reason I started thinking about Dapsone is when Johns Hopkins published that it was a persister bacteria, the light bulb went off in my head and it went, oh, you mean like TB or leprosy? Because when I was doing my internal medicine training at Mount Sinai in New York City back in 1984, 85, 86, 87, we were seeing a lot of HIV patients who had either tuberculosis from immune deficiency or MAI, Mycobacterium avium intracellulare. And I had a lot of experience using TB drugs like INH, rifampin, pyrazinamide. I always wanted to use them, but I needed an excuse to use them. And then when they published the study, it was like, okay, now I've got an excuse. So I went to the literature and I looked up the drugs and I came across, I knew that rifampin and Dapsone was used for leprosy. A 1-year treatment cured leprosy. So I said, gee, let me look up Dapsone and see its qualities. And the interesting part about Dapsone, the drug's been out for 50 years or more. It's anti-inflammatory. So number one, everyone should know who's listening, that every symptom you get from Lyme disease, whether it's acute or chronic, in fact, this is the case actually for all acute and chronic illness, it's always due to inflammation. Whether it's fatigue, pain, brain fog, mood disorders, insomnia, it doesn't matter. It's due to inflammation. So one of the qualities of Dapsone is that it's anti-inflammatory. The second quality of Dapsone that makes it an excellent choice for chronic Lyme is it has wonderful penetration into the central nervous system. In fact, I've not really had to use any IV drugs like Rocephin ever since I've been using Dapsone because the penetration into the brain is so excellent. In fact, I've had patients, and not that I gave it to them, but patients who came to see me that were on 1 year of IV Rocephin, came off and relapsed within 1 month, did double dose Dapsone combination therapy and went into remission for 1 year after an 8-week oral protocol. So it's anti-inflammatory, excellent penetration into the brain. It is a persister drug because they use it for treating persister bacteria like leprosy. It hits the biofilm forms of Borrelia burgdorferi. And the reason we know this is we did a culture study with Eva Shoppe's group for the University of New Haven. And we showed in culture, after 72 hours, if you gave doxycycline, Doxy didn't do a great job knocking down these biofilm persister forms. But if you gave Dapsone, it was way more effective after 72 hours. So it does hit the biofilm persister forms. It's anti-malarial. So again, a lot of these patients have babesia. So you'd like a drug that has anti-malarial properties, right? And it hits autoimmunity. So a lot of these people also get autoimmune reactions. It's been used for diseases like Behçet's syndrome and inflammatory bowel. So the key here is that we find that the drug had like these excellent 5 qualities. So I published the first Dapsone article in 2016. I started with low doses between 25 and 100 milligrams. And we found, whether we used it alone or with doxy or doxy and rifampin,
Mm-hmm.
of the 8 major Lyme symptoms, day sweats, night sweats, chills, fatigue, headaches, joint pain, muscle pain, neuropathy, cognitive issues, insomnia, all of the symptoms got better except for headaches in that initial study. And I've had patients, even in their 80s, who just take 25 milligrams of Dapsone, which is almost like homeopathic dosing. It's so small, with 50 milligrams of Minnow, because they can't do the whole Dapsone protocol. And they come back a month later and they go, Doc, my cognition is much better. Like I thought I had Alzheimer's disease, but no, my brain is working now. So even low doses of this drug will work. And then what I proceeded to do over the next 8 years is I published 9 articles roughly in the last 8 or 9 years, almost one a year, showing each time I would keep increasing the dose of Dapsone. We found it to be more effective. And the funny part is, it wasn't my brilliance in medicine. It was because patients accidentally doubled up the dose.
Okay.
It wasn't like I told them to do it. They made mistakes.
Mm-hmm.
So one guy who was on double dose Dapsone, which is 100 milligrams twice a day, came into my office after 4 months of treatment. He had 3 months of 100 of Dapsone, came in at the fourth month with 100 twice a day and said, Doc, I am feeling horrible. I'm so tired and I got aches and pains and my brain's not working. I said, oh, well, what are you taking? I'm taking Doxy twice a day, rifampin twice a day, and Dapsone twice a day. And he said, oh my God, you're taking too much Dapsone. Stop it and come back in a month.
Mm-hmm.
And he comes back in a month and he says, I feel great. And I went, what? And he got, yeah, like all my symptoms are gone except for the neuropathy. And he had chronic variable immune deficiency because Lyme disease, as well as Bartonella, can knock out your immune system, where you lose your immunoglobulins or subclasses to fight infections. But all of his this guy was in bed for 7, 8 years, couldn't go to school, couldn't work. He felt great. So I said, listen, don't take anything else. I checked him every 3 months. He was in remission until he went to, I think it was New Hampshire, and got like 16 tick bites. Actually, it was Maine. And he got 16 tick bites and then got sick again.
Oh,
so
man.
I then realized, because my wife had been ill for like 25 years, I turned to my beloved wife and I said, honey, would you like to be a guinea pig? This kid just took double dose Dapsone. Now, my wife had done 50 of Dapsone for a year and felt fabulous. But when she stopped it, she relapsed very quickly, and she was PCR positive, DNA positive for Borrelia in her blood, showing it was chronic. She then did 100 of Dapsone for 6 months, felt great again, stopped it and relapsed. And then she did 1 month of double dose Dapsone. And this is before we had the full protocol in place with things like methylene blue that keep down the side effects. My wife's been 6 years in remission since she did 1 month of 100 milligrams of Dapsone twice a day. So the key is, if you have done enough Dapsone and rifampin with doxy and some of the other drugs we'll talk about, it hits these biofilm persisters. And what it is these persisters are dormant in the body and they hide under the biofilm. So sometimes when people say they're seronegative in their immune system, the antibodies are negative. Part of the reason is, well, you might have taken antibiotics shortly after getting a tick bite. It might have knocked out the immune response. But the other thing is the bugs hide under these biofilms where the immune system may not recognize it, and they go dormant. So if you give an antibiotic like amoxicillin or Ceftin or Rocephin, that only hits the actively growing forms of the bugs. The minute you stop it, the bugs go into these persister forms. They go dormant, where some may slowly replicate or they're fully asleep. So you stop your treatments, whether it's herbs or antibiotics, and the symptoms come back. But if you hit the persister load, then what we're finding is these people go into long-term remission as long as, and this is the really important point of this podcast, you don't have active babesia, day sweats, night sweats, chills, flushing, cough, air hunger. You don't have active Bartonella, pain in the soles of your feet. These Bartonella streptomats show up, really severe neuropsychiatric illness. We can get into Bart, in a little bit. But if you have active babesia Bart, then double dose Dapsone is not going to be enough to knock this out. You've got to use some of the newer protocols for babesia with tafenoquine, atovaquone. And with the Dapsone, we found out that if you pulse high dose Dapsone, 400 milligrams just for 6 days in a row, in these 2-week pulses every 2 months, roughly, and I'm estimating, 4 pulses over 8 months, the Bartonella in many times will go into remission. But again, what interferes with the success is if you have mold toxins, you have long COVID, that can interfere, Or if you have overlapping MSIDS variables, and what I mean by MSIDS variables is in these 13,000 people that I've been, looking at them for the last 35 plus years, we found it's like going into a doctor's office with 16 nails in your foot saying, I have foot pain. And if the doctor pulls one nail and says, come back in a month and tell me how you're feeling, obviously you're still going to have foot pain. We find that there are 6 overlapping causes of inflammation and 10 downstream effects of the inflammation that are causing people to stay ill. So the 6 overlapping causes of inflammation is number 1, infections. Now these can be bacterial. For our, in our patients, it's mostly Borrelia, Bartonella, but it could be Mycoplasma, tularemia, it could be all others. The parasites like Babesia, but also viruses, long COVID, or Epstein-Barr reactivation, herpes virus 6 reactivation that happens in long COVID. Or it could be fungal infections, like even Candida. So 1, infections. Number 2 is environmental toxins. Heavy metals and mold is topping the list, although we're all exposed to literally thousands of environmental chemicals every day. Number 3 is the microbiome of your gut. You have the wrong bacteria in your gut. That affects autoimmunity, affects a lot of these symptoms. The 4th, again, is the gut with like leaky gut. We have inflammation in the gut. You get food sensitivities and mast cell activation, where you get inflammatory responses from the food you're eating or from the environmental toxins. The 5th is insomnia. If you don't fall asleep, the inflammatory response doesn't shut off. And the 6th is vitamin mineral deficiencies. So it's almost like having 6 rivers of inflammation causing an ocean of inflammation. And then this inflammation has 10 downstream effects, making you tired, achy, with brain fog. And that's mitochondrial dysfunction. The part of your body that makes energy has nothing to protect it against the free radical oxidative stress from all the inflammation you get. Or you may have POTS dysautonomia, the part of your autonomic nervous system that controls your blood pressure and heart rate gets affected. You get it with Lyme and Bart, you get it with mold, you get it with long COVID. Or your hormones are affected because the inflammation affects your pituitary, the master hormone in your brain, and the adrenal glands don't make enough adrenal hormones, or men come in with low testosterone, or women lose their sex hormones. So, and you get neurological problems, psychological problems, liver dysfunction, immune dysfunction with autoimmunity, or immune dysfunction with absolutely no immune function whatsoever in some of these patients, including deconditioning, liver issues. So if you look up in my books, why can't I get better? How can I get better? You can read about these 16 points, although I did publish an article in the journal Healthcare in 2018. If you don't want to spend the $12 on Amazon to get the books, you can just read this article for free. And it explains in these 200 patients, you'll see all the MSIDS factors we found. And really what's important for people to realize, no one at this point comes into my office with just chronic Lyme disease. It never, ever happens. They mostly have Babesia and Bartonella. They have mold toxins. Many have long COVID. They have hormone disruption, POTS. So honestly, the key for most people who are still sick, you got to go back to the 16-point MSIDS model and work with your doctor to look at all these factors. And I will tell you right now, you can have hope because the vast majority of our people are getting better with the Dapsone protocol and addressing all the abnormalities on the 16-point MSIDS model.
From just Dapsone alone.
Dapsone, rifampin, and so the protocol is, the minimum protocol is rifampin, Dapsone, and either doxycycline or minocycline. Okay. So there's 3 antibiotics. I do it with Plaquenil, hydroxychloroquine, because it hits the cystic forms of Borrelia, as we talked about, helps with autoimmunity.
Nice.
We use nystatin just to keep down yeast in the colon with a very low carb diet.
Good. We
give people like 500 billion probiotics twice a day of 4 different types to make sure they're getting all of what they need. We haven't seen a case of C. diff in our practice, honestly, in years at this point. And there's a lot of supplements to block the inflammatory response because the Herxheimer reactions, when you're killing these bugs, people can get a lot of inflammation with more fatigue, more brain fog, more pain. So you're swallowing literally, I'm not exaggerating, 70 or 80 pills a day, which by the way, if I went down to my kitchen, if I took my computer down to the kitchen right now and I showed you my kitchen cabinet, what I swallow every day, I'm already swallowing 70 pills to stay alive on the planet at this point. I just know too much. But no, so it's a lot of pills, but it's only an 8 to 9 week oral protocol. And, you know, if you're a woman, you're a little anemic, you may have a problem getting through the whole protocol because one of the side effects of Dapsone is a folic acid induced anemia. And you also have to worry for things like methemoglobin levels, which is where you don't carry oxygen well in the blood.
Right.
But we figured out how to get past it with using things like methylene blue, which is a persister drug for Lyme and Bart, lowers methemoglobin. Cimetidine, the old drug for the stomach, lowers methemoglobin. Glutathione, that I use for herxes, lowers methemoglobin. So does vitamin C and E and NADH, which we use for mitochondrial function. So I've been tweaking the protocols for years, and I've got it down to roughly a 9-week oral protocol, followed by 2-week pulses, roughly 4 times if you have BART. And most people will get over this illness. Again, while I'm not doing the antibiotics, I'm treating mold. I'm working on the hormones. I'm working on the POTS. But you got to keep the checklist going of all the MSIDS factors keeping you ill. But it's at least 3 antibiotics. But in the second month of Dapsone, I do use Zithromax. And the reason I use it is in the culture studies we did, and this has been proven from Hopkins and Tufts. Tufts University and Hopkins both showed that 4 antibiotics works better than 3, and 3 antibiotics works better than 2, and 2 antibiotics works better than 1. So these doctors out there that are using a single antibiotic for chronic Lyme, I'm letting you know it's not a great idea because these persister bugs, they don't respond to single drug regimens. So if you look at our work from Eva Shapi, Hopkins, and Tufts, they're all in concordance that 4-drug regimen. So the 4-drug regimen is a tetracycline, rifampin, Dapsone, and Zithro. Now, the 5th drug we use with Bartonella is pyrazinamide, because pyrazinamide is also a persister drug they've used for tuberculosis to shorten the course of TB treatment. And I had a BART patient years ago who was an autoimmune patient with Behçet's disease. She had these big lesions on her tongue, these ulcers and other parts of her body, sick for 20 years. Nothing the rheumatologist did helped her. I put her on doxyrifampin Dapsone. She got better, but the lesions never went away until I gave her pyrazinamide. And all of a sudden, she turned around. The lesions went away for the first time in 20 years, but her Bartonella titers that were negative turned positive because when I went into the intracellular compartment, by the way, doxy, rifampin, cythropyrazinamide all go intracellular, which is where the bugs are generally hiding, and it flushed them out of hiding, and the Bartonella titers turned positive. Her tularemia titers went up 4-fold. She had tularemia and didn't know it, and it became active, and her herpes virus 6 titers reactivated. So we went in there, and we kind of pissed off all the bugs that were hiding in the intracellular compartment. So I do use a 5th drug, pyrazinamide, for BART, but I will tell you I do need more like randomized controlled studies in larger patients to see how effective pyrazinamide is. And this year, I am now starting to apply for NIH grants for a multi-center, placebo-controlled, randomized trial to prove to the world that I actually have answers for chronic Lyme and I can give hope to the world because by the way, we are in a full epidemic. BMJ Global Health published about 2 years ago that 14.5% of the global population, 1 out of 7 people on the planet, has now been exposed to Lyme. And the CDC said this past year, it's 6,000 a year. And then they came out a few months later and said, well, it's actually 1.7 times higher. Well, that puts us in around the 650 range. And then they said, Medicare recipients, it's 7 times higher. What are we dealing with? 3 million people a year, like 1% of the American public is getting Lyme disease? We're in the middle of a full-blown epidemic. So I don't care where you live in the U.S., where you live in the world, just like COVID, it is all over at this point, and you have to suspect, no matter where you live, that if you have a chronic fatiguing, musculoskeletal, cardiovascular, neuropsychiatric illness, it's got to be on the top of your differential diagnosis to figure out why you're ill.
Right on.
That was a long-winded conversation to explain pretty much everything I'm doing in the last 40 years.
It was great. I have so many questions bouncing around in my head. I don't know about you, Patrick, but I do.
One thing I appreciate you is about you is you like to go after the cause of people's disease presentations. You don't find that a lot with medicine. I don't see that a lot with medicine. In my own experience and my story, while I was in my medical program, I had chronic symptoms that I learned to manage for many years. I was a health nut my whole adult life, and I developed chronic symptoms. Finally, I was taken down with bowel obstruction over and over and over again. three times, almost lost my life. I looked at the doctors, the GI specialists in the hospital, and I asked them, I said, so what is they wanted to diagnose me with MS and Crohn's disease based on my symptoms. And they wanted to do further diagnostics. And I asked them, I said, so what's the cause of Crohn's disease and or, MS? And they said, Patrick, unfortunately, there is no known cause. And it's just something that happens. Your symptoms don't really matter. It's just an unfortunate period in life that you are going through right now. And you're going to have to be on medications, hardcore immune suppressants for the rest of your life. And you are going to have to go down the road of further testing in regards to, diagnostics in terms of confirming that you have MS and confirming that you have Crohn's disease. And you may need procedures to help keep you stable for the rest of your life, but your life will never be the same. And I went a year of trying to figure out, I looked at them and I said, okay, all right, thank you. Just to satisfy them so I could be released, from the hospital. And, I went on this journey of trying to figure out what the cause was of, my symptom presentation. And I probably went to like 20 different doctors throughout this over a period of a year. I finally learned what was going on with me from a doctor who founded the university that I was attending at the time, Oregon College of Oriental Medicine. Dr. Satya Ambrose, who's an ND who specializes in Lyme disease and co-infections. And light bulbs were going off in my head every single day. And finally, I got it. I was like, okay, I have chronic infections. This is a no-brainer. Why didn't I think about this in the first place? I have chronic immune reactions. I have chronic infections, and I have this, and this. I didn't even need to go down the road of testing because I had the symptoms. And, she did the legwork of teaching me that she had learned from you. And, it's just, I'm kind of like in question, why is it in allopathic medicine that you find 99%, at least in my experience, of doctors, they don't go digging for the cause of chronic illness. And,
I can give you the short answer on that one, and I don't mean to piss off. I don't mean to piss off the pharmaceutical companies, but you may know that a good part of the medical training that we get is sponsored by Big Pharma. And don't get me wrong.
All right.
I love Big Pharma from the point of view.
For sure.
I take Montelukast for my asthma and allergies. Game changer. I love it. Thank God someone developed the pill. I have nothing against drugs in Big Pharma, but what they didn't do, because obviously Dapsone and all these drugs were developed by Big Pharma.
Mm-hmm.
But what they don't do in medical school, because it's basically name the disease, throw a drug at it. Name the disease, throw a drug at it. So, and by the way, when you were saying, what are the root causes of Crohn's and MS? We actually, by the way, we do know what causes Crohn's and MS. And I'll tell you this is interesting. If you go through the literature, you'll find that there are mycobacteria, the same thing we just discussed with Dapsone. You'll find that there's articles in the medical literature about mycobacteria and inflammatory bowel disease. You'll see the same for some of the tick-borne infections causing it. Now long COVID, by the way, the virus is showing up in the gut causing inflammatory bowel. And with MS, for years they talked about chlamydia pneumonia, low vitamin D. But the problem with MS is it's an inflammatory demyelinating illness. But the problem is demyelination, when we talk about neuropathy earlier, demyelination is caused by Lyme, it's caused by BART, right? It's caused by autoimmune reactions, it's caused by heavy metals like mercury, lead, arsenic cause neuropathy. So you're dealing with a multifactorial cause, and unfortunately, root causes are more taught in naturopathic school than they are in classical allopathic school. And I meet a lot of naturopaths who say to me, you think more like a naturopath than like a classic doctor. And it's like, and maybe it was the 7-year training I got in Belgium, regarding that. I don't really know. It's just, it made sense that, but the multiple root causes, that is really something I didn't even know in naturopathic school how much they teach it. But in this day and age, what it's come down to
Yeah.
is the 16 points on the MSIDS model. Just to let you know, Simon and Schuster just gave me a contract for my next science book.
Yeah.
I'm in
Wow.
the process of writing it.
Mhm.
And it's
Awesome.
only a small portion on Lyme.
Yeah.
It's actually about the diseases you just mentioned. The name of the book will change 100 times before it's done. But,
Yeah.
but temporarily it's being caused why we stay sick. And it's about the chronic disease epidemics in our country and the world. And by the way, MS will be in it, Crohn's
Mhm.
disease, all those diseases. And I will show you that when you do a deep dive in the medical literature, all 16 factors for these
Mhm.
chronic diseases are showing up in literally every chronic illness you can name. And we
Mhm.
have not integrated that into the medical systems. We're really great with acute diseases, but where the medical system has failed us in general, it really has not taught doctors well how to deal with chronic illness. And
Right.
I feel if you want to change the medical system, the only way it's going to happen, chronic disease centers of excellence, because in an HMO model, 15 minutes with a doctor is not going to be enough with somebody who has 38 symptoms. And
Mhm.
secondly, and you know this, you need several hours with a
Yeah.
patient on the
Yeah.
first history and physical to really get a proper
Sure.
history.
Definitely. Yeah.
Eventually, hopefully, we'll get a digital model that'll help. And you also need chronic disease centers of prevention because we're dealing with the long range effects of infections and toxins driving autoimmunity and all these other things. But if you could get people in the prevention mode early on, before the diabetes got worse, before the hypertension caused strokes, heart attacks, and kidney failure, we wouldn't be seeing a lot of these chronic disease epidemics, right?
Mhm.
Long COVID, of course, will be an exception because we're still figuring out pieces of it. But
Yeah.
I don't see how the healthcare system is going to survive because it's something like 18% of our
Mhm.
GDP every year is
Yeah.
used for chronic disease. That 86% of our healthcare costs and 70% of the deaths in our country are due to chronic disease. And
Mhm.
no one at the top of the healthcare model has a healthcare kind of overview like the MSIDS model saying that is a logical model to use for chronic illness. Let's start integrating it and let's do some long-term multi-center studies and let's see how we do. But that's essentially what I've been finding.
Yes.
Mhm.
Okay. Great.
Wow. I have an interesting question. You you're talking about all these different chronic illnesses, and it sounds like a lot of it is pathogenic. Are you seeing, especially with things like Lyme, uh, a change? Is there something evolutionary happening, or are we just getting better at our research and understanding what Lyme or these other chronic illnesses actually are?
That's a good question. So, I mean, definitely the education online. And by the way, any benefit that I have done for patients is thank God for all the research money that went to Hopkins and
Right.
Stanford and
Mhm.
Evershot, because if it wasn't for these great PhD researchers, none of
Mhm.
what I do would have even been possible, right?
I
Yeah.
agree. Yeah.
The research has definitely given us much more education in the last 10 years. I think there's been an
Yeah.
explosion.
Mhm.
I mean, I started looking at MSIDS factors. As I said, the article I published in Healthcare was back in 2018. And by the way, with long COVID, when I published the 16-point model in Healthcare in 2018, if you look now, this past year, I published an article in Microorganisms, April 2024, and I showed that all the factors that have now been associated with long COVID, all 16 points on the MSIDS model we see in chronic Lyme has now been associated with long COVID.
Okay.
One of
Oh.
them. The only difference is one was caused by a virus, one is caused by a bacteria, but they're also finding, by the way, in the long COVID population, a
Mhm.
lot of Lyme and a lot of Bartonella,
Mm.
including mold. So truthfully, these diseases are starting to
Yeah.
overlap.
Right.
And the difference from the point of view of long COVID is long COVID, if it was a pure virus, is not going to cause migratory joint pain like you're going to see
Mhm.
with Lyme, right?
Mhm.
And if you look at radiance diagnostics and some of the chemokines and cytokines that Bruce Patterson is looking at
Mhm.
on his panel, you can look at the panel, by the way, for those of you who've never looked at it, it's at www.covidlonghaulers with an S. They have a
Mhm.
14 cytokine panel, and you can look at the cytokines and go, oh, IL-6, IL-10, oh, those are associated with Lyme. But, IL-2, IL-4, these other ones were associated, CCR5 rantes is associated with long COVID, with VGF, although VGF is seen with BART as well as long COVID. But you could actually see the difference in the inflammatory cytokines, and some of them overlap completely with these diseases. So the research, I think, has exploded in the last 10 years, which has allowed us really to understand it better. Without the knowledge, by the way, of biofilms and persisters, I
Mhm.
would not have had the answers that I have now. From my perspective, Dapsone combination therapy is going to turn out to be potentially a cure. And the only reason I can even use that word is Tufts University last year, Monica Embers published a study in mice that showed that rifampin and dapsone cured mice that had chronic Lyme. They could not find the infection in mice. Now, it's one animal model, but we have a culture model showing that combination therapy lowers the biofilm. We have animal models, and I have 8 clinical studies. So now the next step is a multi-center randomized placebo-controlled trial. And that's why I'm applying for NIH grants. And, hopefully I'll get enough that we'll be able to get the funds to do it.
Wow. That's
Dr.
incredible.
Horowitz, how do you treat people with Rocky Mountain spotted fever, rickettsia, as well as relapsing fever?
So we do the thing that people need to know about Rocky Mountain spotted fever. It's good you brought that up.
Yeah.
So normally Rocky Mountain spotted fever, you're going to be getting it from, for example, dog ticks, wood ticks, and the Lone Star tick. So the Lone Star tick, which is now spread from New York, Rhode Island, all the way up to Maine, going into Canada, it has a classical white dot on the back, and it will spread what I call, this is the mnemonic I use to memorize it. It's called TEARS with a V, stands for tularemia, Ehrlichia, alpha-gal, R for rickettsia, Rocky Mountain spotted fever, S for stari, southern tick-associated rash-like illness, and viruses like the Bourbon and Heartland virus. But dog ticks, for example, wood ticks, dog ticks also transmit rickettsia like Rocky Mountain. Now,
Mosquitoes as well.
If you get bit by a Lone Star tick or a dog tick, and you start getting ill, you need to immediately do a CBC and a CMP, a biochem profile, because if you get low white cell counts, called leukopenia in medicine, and or low platelet counts, called thrombocytopenia in medicine, and or elevated liver functions called transaminitis, any 1, 2, or 3 of those symptoms, you immediately put the patient on doxycycline. You do not wait for antibodies to come back for Rocky Mountain spotted fever, because only 50 to 60% get the rash on their hands or their feet by day 6. And by that time, you could already be close to death from a rickettsial infection. Now, this is important because there are kids that have died because the pediatrician did not want to give them doxycycline, except doxycycline does not cause teeth staining in children. And you can give a 7 to 10 day course in a child, and you can give it even to a pregnant woman. And this comes right out of the mouth of CDC when I worked with them at the HHS first round of the tick-borne working group. So, I was elected on the first round of the HHS tick-borne disease working group, where I worked with the CDC, the NIH, the FDA, and the Department of Defense. And I worked with somebody from the CDC who taught me this on rickettsial infections. But also, 10% of the Rocky Mountain spotted fever titers you get that are positive are false positives. They're overlapping other diseases. So when you brought up rickettsia, I thought, oh, that's a great kind of segue to tell people, if you suspect this from dog ticks, wood ticks, Lone Star ticks, if you suspect sick, you go on doxy immediately. Do not wait for antibodies. But you can get false positives, because if someone said, I had Rocky Mountain spotted fever and I'm well, it's like, I'm not sure you had Rocky Mountain. That might have been a false positive. But you will get, by the way, cross-reactivity with other species, right? So there's now a form of rickettsia called Rickettsia parkeri that is in the Gulf Coast ticks in, for example, the boroughs now, like Staten Island, that's shown up. And it's less severe than Rocky Mountain spotted fever. People get an eschar. They get like a little area you can see where the tick actually bites you. And it's not as severe, but it still responds. And regarding tick-borne relapsing fever, the answer is yes. We see positive tick-borne relapsing fever immunoblots all the time. Now, the tricky part is, it's good you brought this up. If you see a patient and it looks like Lyme and it smells like Lyme, but you're not getting back Lyme testing, you need to be checking for relapsing fever, because there's soft tick relapsing fever and hard tick relapsing fever, which is Borrelia miyamotoi. And you can get Lyme-like symptoms with that, especially in the immunosuppressed patients. Those are the ones who get the worst symptoms. Right. But you can get that and say, gee, I can't find evidence of Lyme, but it's because it's like a cousin of Lyme disease, right, with relapsing fever. So, yeah, these are 2 good points. I'm glad you brought that up.
Okay. So, Dr. Horowitz, can you get these pathogens also from mosquitoes?
It's never been proven at this point that Lyme can be transmitted by mosquitoes, but I will tell you what does get transmitted by multiple pathogens is Bartonella. So there's only one study in ticks in Europe, in Ixodes ricinus ticks in Europe, where they transmitted a particular species of Bartonella called Bartonella Bertzelli, Bertolesi. And this particular species is the only one they ever published that ticks transmit, because many of the ticks now have Bartonella in them. And it's been a controversy in science, like, do ticks transmit? The truth is, it doesn't matter, because whether you get it from a flea bite,
Right.
or red ants, or a
Yes.
spider bite, or
Right.
keds, or mites, or lice, or mosquito, it doesn't matter at this point. Bartonella is transmitted by at least 10 different, species out there. That is the one I think that's transmitting probably. It's like the highest vector-borne illness being transmitted from all these different species. And I saw Ed Breichwert, who just talked about BART at the ILADS conference in San Antonio just a few days ago. The number of species that transmit, but we don't have it yet for mosquitoes. Willy Bergdorfer, by the way, interesting you bring that up. Willy Bergdorfer, I think, was finding them, but it's never been shown to be capable of transmitting. And it's the same thing with Haemophilus longicornis, the Asian bush tick that's now spreading. It's a hermaphrodite. It doesn't need to feed off of animals. It's spreading like wildfire throughout the U.S. And this tick contains Borrelia burgdorferi. It contains rickettsia. It contains the Heartlands and Bourbon virus, but it doesn't necessarily transmit. Its ability to transmit yet has not been proven, thank God, because in Europe and in Asia, it transmits alpha-gal. It transmits virus infections like severe fever and thrombocytopenia syndrome. But so far, this tick has not been possible, has been not shown able to transmit, but it can kill off cattle or moose by sucking them dry. I mean, in Maine, there's moose that are dead on the side of the road because there's so many ticks on them, it just suck them dry. So, but yeah, it's a good question on pathogens of which ones can transmit. Not yet, but what I will tell you, I worry about with the mosquitoes is this cases of triple E, of equine encephalitis that are starting, West Nihilus, flavivirus, dengue virus, right? Some of these flavivirus infections are starting to go up. We're seeing bird flu. We're seeing cases start to be spreading now, right? So a lot of the viral infections, bird flu, monkeypox, Oropush virus, which nobody even heard of this virus, months ago. There are now all of these viruses spreading. And by the way, for people who want updates on all the stuff I'm discussing, I started a Substack called Medical Detective. And Medical Detective Substack, every week, I publish an article on something new. I did like 10 on Lyme disease, 5 on these viruses I'm telling you about. I did 1 on why Chris Christopherson didn't have Alzheimer's. And it's free to sign up.
Nice.
People who've been reading the Substacks, I guarantee you will enjoy it. The last one I did last week was on hysteria of women in upstate New York who were diagnosed with hysteria. It turned out they had pans pandus, and they were diagnosed, with hysterical reaction, like from Freud's time. If for those who want to follow me on Facebook. It's Dr. Dr. Richard Horowitz. Any updates in medicine I put on Facebook or the Medical Detective Substack. I know you're going to love it because I'm educating both doctors and patients alike. The medical terms are explained in lay terms, so you can understand it. And my bizarre sense of humor is getting thrown into the Substacks at the same point in time.
I love it. And I've signed up myself.
Yep, same here. I love them. And I love I really love the hysteria article, especially.
It was a fun one. It was a fun one to write.
Very good, and relatable. Especially myself, my Lyme journey. I kind of went through something like that, and I found it very interesting. You pointed out women tend to be the ones that get the hysteria label, and
women get gaslighted way more than men do.
I know, and I am so sad to say it, because I will say my excellent doctors that I had when, I have Lyme, but I went through that, and it was awful. I went through this period of, well, maybe we should look at antidepressants or something like that. And it's very disheartening, especially when you're really ill. And I had very strange outward signs. I actually went bald, and I started having neuropathy and trouble walking and all these things that are clear physical signs. But in spite of this, being told, we think it's...
You went bald with neuropathy and the doctors told you it was in your head?
Yes, they did. Yeah. You
may want to go back for a little more medical training.
Yeah. But I think it's the thing that we talked about a little earlier, why are doctors, when they don't have an answer, it seems to be, I hear this from a lot of other people who've been through chronic illness, that's the go-to answer. Is it something to do with they don't have time to treat people and they just need to next, or is it the way they're trained? What do you think is happening there, and what can patients do that you would recommend to self-advocate in situations like that?
Great question. So first of all, if you have psychological symptoms, which by the way, every tick-borne disease causes it, and so do toxins, by the way,
Mhm.
mycotoxins, heavy metals, there's a lot of physical causes for neuropsychiatric symptoms.
Mhm.
But when patients come in and say, the doctor told me it's in my head, I usually
Mhm.
validate them and go, well, the doctor was right. You have Borrelia burgdorferi in your head. You have toxins in your head. I mean, I kind of make fun of it, but it's like
Mhm.
they were right, but not the way, of course, they were told it's right. Um,
Mhm.
the thing about it is physical symptoms with neuropsychiatric, you have to assume there's going to be a physical cause, at least in part. Now, by the way, that doesn't mean that most of us living on this planet have not had trauma,
Mhm.
myself included.
Mhm.
You are allowed to have trauma in your life that causes limbic dysfunction in your brain and gets you, depressed, stressed, anxious, depressed, etc. And then you get a tick-borne disorder or you get mold toxins that just makes it much worse. But it
Mhm.
doesn't mean like it's all in your head. And I think it's just honestly poor training. The doctor should have been taught in medical school. If
Mhm.
a patient comes in, if you can't figure it out,
Mhm.
really your job, and this is again, I'll go back to what Lama Rinpoche told me at the beginning of this podcast when he said,
Mhm.
put yourself in people's shoes and do for them what you would want done.
Mhm.
With that advice, it's like, oh, well, gee, I can't figure out what's wrong with them. And the subspecialist couldn't figure out what's wrong with them. It's my responsibility to go back to the drawing board and look
Mhm.
it up. And honestly, in this day and age, without it being rocket science, if you go to the 16-point MSIDS model, I don't want to
Mhm.
oversimplify it, but truthfully,
Yeah.
you'll usually find the answers in my books and in my
Mhm.
publications because this is what I've seen in these 13,000 chronically ill patients that it's not one thing making them ill. And unfortunately, neuropsychiatric symptoms overlap. And with
Mhm.
BART, for example, which really makes the neuropsychiatric symptoms worse, schizophrenia,
Mhm.
obsessive compulsive disorder, severe anxiety. I mean, really bad neuropsychiatric symptoms from a bacterial infection.
Yeah.
I've had
Mhm.
people hallucinations go away
Yeah.
after being treated for BART. They got off all their schizophrenia drugs.
Mhm.
Mhm.
So it's poor training in medicine where I don't know if it's hubris, like if I can't figure it out, it can't possibly be real. But
Mhm.
honestly, what they should have been taught in med school is you can't assume. The last thing you want to assume is that
Mhm.
it's in someone's head and that
Mhm.
that's the reason that they're sick and that but they've also not been taught like chronic disease medicine or functional medicine is not normally taught in med school. So they
Right.
honestly don't know where to look. And that's why
Mhm.
reading my books and reading my
Mhm.
publications, it's a good starting point for a lot of these doctors, right?
Mhm.
Yeah.
Definitely.
Yeah.
Mhm.
There is hope for chronic Lyme in these illnesses. I've been looking for it. And again, please watch for the next book, watch the medical detective Substacks, watch Facebook, but please do not give up. Do not have hope. Contact people like Patrick, contact people like me. If you can't find an answer and you are giving up,
Mhm.
you've got to contact us or other doctors who contact us to
Yeah.
please let us help you
Mhm.
because the human life is extremely precious. You do not want to say there's no answers. There are answers, including for some of the diseases, Patrick, that you brought up today, that
Yeah.
people say, there's no answers. There are answers.
There are.
And we're gonna get to this as time goes on, but
Mhm.
it's the paradigm shift in the chronic disease model that again you brought up so beautifully today. That is going to be needed to help these people with not just what we call chronic Lyme disease, but many of these chronic fatiguing musculoskeletal or neuropsychiatric illnesses that have so many different causes.
Right. Right on.
Thank
Thank you
you
very much,
so
Dr.
much.